Welcome to CarePod, a safe place to educate, inspire, and renew the caregiver. Listen in with our host, Dr. Kiplee Bell, as she interviews different experts along the caregiving journey.
So I'm here today with Mike Newell of Lifespan Care Management, a really unique and necessary niche to come in, enter into the family space, and get the house in order. So I'm really excited to have the opportunity to speak with Mr. Newell and understand specifically how he helps families, how his company has had impact in terms of navigating the healthcare space for families. So very, very good conversation, I anticipate. So welcome to the Care Pod. Thank you so much.
Thank you.
Yeah.
Thanks for having me on.
Yeah. So question, before we get into the nuts and bolts, tell me critical care nursing, tell me your journey. I always love to begin with the person's why.
Right. So the whole journey is I'm the oldest of 11 kids.
Wow.
When I was 9, my mother had a set of twin boys, and when I was 11, she had another set. So I spent a lot of my teenage years changing diapers and whatnot, and trying to put myself through school. I was a psych major and got a job in a mental hospital, and I saw the nurses were doing more for the patients than the mental health workers. And so I took a left turn and went to Philadelphia Community College and got an associate degree in nursing, and did go into psych and found that nobody's really getting better here. So we made another turn and wound up in critical care. So I have 40,000 hours at the bedside in the ICU and emergency room, mostly in tertiary care hospitals, but also part of that was doing agency work where, you're a hired gun, you go and a lot of those are inner city hospitals in Philadelphia. Moved back to New Jersey, did work, in the critical care at Cooper, the Virtuas, and kept going to school. So I have a master's in nursing administration. The focus was on managed care and case management as a component of that. And I got a job in what's called a private rehab company. Their customers were smaller insurance companies, generally, that did workers' comp insurance, long-term disability insurance. Major medical was still around at the time.
Yeah.
And auto was still $2 million coverage. Now it's 200,000 if you get catastrophically injured. That burns up in about 3 days in the trauma unit. Anyway, so a lot of those cases aren't case managed anymore. But I found I was good at it and I would follow the patient from the trauma unit to the step down floor to the rehab hospital to home modifications, go to doctor's appointments, justify the care to the adjuster, very important. So they taught me how insurance companies think, which assists us in terms of advocating for our clients now, because we do insurance appeals, and I won't get to that.
Wow.
Wow. Yeah. So mostly our customers are the sons and daughters of older adults who are concerned about their parents. They may live close by or may not live close by. Probably more than half of those referrals come from elder and estate attorneys, sometimes from financial advisors or other trusted advisors to the family. So, and a lot of the referrals come from when there's a crisis. Mom has already fallen. She broke her hip. She got it fixed. She went to the subacute, and she's been there 3 weeks or so, and they're trying to kick her out, and the family's not ready. And they just don't know what to do. So first thing is we go in and we assess the person, what was their function before, and try to get an idea of what would be their optimal function given the injuries and the chronic illness, because there's generally multiple chronic illnesses they already have, and try to determine, what would be their optimal recovery, and would they be able to go home? If not, what's plan B, and how are we going to help get it paid for, right? How best to spend that money. But a lot of times in subacute, they're just looking at the rehab piece, and they're not looking at the complexity of the medical management. And so the insurance company, and sometimes even the facility itself will say, we're going to get stiffed by the insurance company, so we're going to give the family a piece of paper that says the insurance company may not pay for your continued care.
Yeah.
Well, that's not an official notice.
Yeah, or
So,
that magic 14-day, you know,
yeah,
magic number that,
yeah,
we have done the best to rehabilitate you. And now, we need to usher you on to home or to
yeah,
long-term care or whatever it may look like. So, all
yeah,
right, so let me back you up a little bit. You had said something about really getting into the mind of the insurance company
right,
to basically help the caregiver advocate for their loved one with getting items paid for their care.
right.
So, what does that look like?
Well, first of all, you need to know what kind of insurance. So, big problem right now is these Medicare Advantage plans,
Yeah.
right? So, if you have regular Medicare and you have Part B, correct? There's an insurance company that is adjudicating the claims on behalf of Medicare. So if they meet the Medicare terms of participation, if it's appropriate care, given computer algorithms, the care gets paid for, right? And if Medicare or the FI will pay for that, then the Medicare Part B, the supplemental, will pay for it as well. Okay. If you have a Medicare Advantage plan, it's like an HMO. They get so much per month from each of their subscribers. It goes into their bank account. Now it's their money. It's not Medicare's money. It's their money, and they don't want to spend it. Okay.
Hmm.
So Medicare, if you see the ads, they'll say, oh, if you live in a certain zip code, you qualify for extra money for groceries and things like this, right? Eyeglasses, whatever. Well, that's because the feds recognize that if you live in certain zip codes, you're more likely to have chronic illness, and we want to keep you out of the hospital and the nursing home. And that's really what the design is there. But the Medicare Advantage plans, they're just milking the system.
And
Okay.
it's really refreshing to hear that because, I am definitely a traditional Medicare and get your Medigap plan because I
Yes,
have found that these advantages are smoke and mirrors for
they
patients and
absolutely are.
families.
It's a fraud. It's a
Mhm,
fraud. And
mhm,
they're not just frauding the subscribers, they're frauding Medicare in other ways, but we won't get into that.
mhm,
But
mhm,
there's a lot that they're doing, and that's why they're spending so much money on advertising. I
mhm,
mean,
mhm,
it's relentless. At
mhm,
any rate, so they'll, you know, most older people, if you put them in bed for 3 days, they lose enough function, right, that they do need a rehab tune-up. So they go to a nursing home. A lot of those patients were hospital patients 20 years ago, even 10
mhm,
years ago, right?
mhm,
Now
mhm,
they wind up in a nursing home model, the staffing model. The staffing isn't great, the training isn't great, the supervision support isn't great, the medical management piece is iffy, and the nurses don't even know what they don't know, because a lot of times the chart that they get from the hospital is incomplete, or not well focused, so they
mhm,
don't even know what they're doing with this. So they just go through the routine, which is giving them the meds, and then PT. So the PT, and they call themselves rehab. It's not really rehab like an acute rehab, Kessler and
Right.
Moss,
Right.
because the nurses don't know anything about rehab, and they don't discuss the rehab plan with the therapists. Right, the therapists go and do their own thing. The nurses don't know anything about how they're doing, what they're doing, and vice versa. The therapy doesn't know what meds they're on or really too much about the diagnosis. So it's really, trying to glom on some rehab onto a long-term care nursing model.
Mm-hmm.
Right. And all the nursing homes want to get in on that because it's Medicare money. It's more than they would be making if they were, getting cash or even, a Medicaid, what the state pays for the Medicaid bed.
Mm-hmm.
So,
So let
yeah.
me interrupt you there too. What so where does lifespan kind of change the game? One, and two, uh, where is the help for the gap on those that make too much for Medicaid, but don't, aren't benefiting from all the services that are available to those that are on Medicare, have Medigap plans, work their whole life, all the stories, but don't, aren't able to benefit from the Medicaid services that are available. Um, I have heard that there's some billing to change around that, but I don't know how accurate that is. So, for example, my Medicaid patients can benefit from the stipend that's paid to their caregiver to, that can be a known person or a family member to them, but cannot actually get a stipend. But like, I can't get a stipend to pay someone, for instance, for my own mother who has Medicare and a Medigap plan and worked her whole life as a nurse. So, you know, how is lifespan change the game in terms of kind of coming in to make patients aware of, this phenomena that's going on, if you will? And then two, are there any changes or things that we can anticipate for the Medicare patient, the traditional Medicare patient?
Okay, so first of all, like we're doing this on a case by case basis. So,
Mhm,
not all Medicare Advantage plans are the same.
mhm, mhm,
Okay, so for example, if you worked for, you know, uh, um, Goldman Sachs,
mhm.
right? And Goldman Sachs said,
A
"Oh,
buzzword.
we have a retirement plan for you,
Right.
and it's an all-inclusive plan, right?" They may try to chisel you, but when they get challenged, they back off. So I've gotten patients with that type of Medicare, that a big corporation. They were in subacute. The subacute said, "Okay, you're not making any progress. You need to go away." And we're there like, let's call Kessler and see if they think that this person is appropriate for their program. They can do 3 to 5 hours of rehab a day. They can do more than 3 hours, right? And Kessler says, yeah, we can help them. Okay, so we've gotten them to go, instead of getting kicked out altogether, they get step up, to real rehab,
Yeah,
right?
yeah.
And they might have needed to hang out a little bit to recover enough to get to the point where they could do 3 to 5 hours a day, right? So, but then other plans, and one of the things in New Jersey is all the the teachers union and the state employees got put into a Medicare Advantage plan. Okay,
Mm,
well, what is this? And because the state has an obligation to pay for their health insurance under their contract. Well, what are they actually paying for that? Probably almost nothing,
mm,
right? Because the Medicare dollars go right into the HMO and they don't want to pay, right? So, so what we do is first of all address what are the care needs of this person right now, which a lot of times, they're not doing well clinically, and so they can engage in rehab. So
mhm,
let's talk about that first.
mhm,
Okay. So
mhm,
we assess them from the clinical perspective, and being aware of the Medicare rules. We assist the family to do the appeals. If you're going to do an appeal, you have to go all the way to the end, right? The appeal process for traditional Medicare, for commercial insurance, and for Medicare Advantage plans are all a little bit different, but the same idea comes into play in terms of, you address, first of all, we say, look, don't just tell us we're denied and give us an 800 number to call, and 20 minutes later they're going to say no. We don't even know why we're being denied. So we want it on paper, and we want a reason.
Gotcha.
Like, not this may happen or that may happen, or you don't meet the criteria. It's all baloney. So that slows down the process. And then, we help them write an appeal letter that says, first of all, that there's more complexity here than than you've really screened for. That because a denial of care, this is critical. A denial of care will impair the person's function and quality of life now and in the future. Need that phrase, okay? And challenge them. And then so, the insurance companies know that 60% of the time nobody will appeal a denial. They won't appeal the second time they're denied, 60% of the time. So go all the way to the end. At the end, there is some sort of independent arbiter, okay? It might be an administrative law judge from Medicare, and you send all the documentation to them, and 3 months later you have an appeal. Or it might be a board certified a peer review organization that does that. So I'm sure for yourself that you have these peer-to-peer conversations, and you have it's a trauma thing, and you're talking to a psychiatrist, like,
Oh yeah.
It's completely, or it's a pediatrician. Like, what are we talking
That
about?
hasn't touched a patient in 20 years,
Yeah, well, that too.
Impactful caregiving begins with you. Become an educated and empowered caregiver to best serve the one you love. Impactful Caregiving offers online geriatric certification, personally curated items for the older adult person in our caregiver shop, Geri telehealth options, and of course, your personal dose of inspiration here on the Care Pod. Go to impactfulcaregiving.com.
In 20 years,
Well, that too.
And I think it's important too for patients to understand these limits that are placed on clinicians as a result of being insured. It's almost, which is why you've seen this emergence of concierge practices and fee for service and all the things, because you spend more time and money in the aggravation than just paying for the good service and calling it a day. I get it. So what has been your greatest impact as an organization? And what does the fee structure look like? So if somebody wants to do private pay, they say, listen, I need you to come in, give us a plan for our loved one's care. And then what are those next steps? Like, are you in collaboration with clinicians, providers, therapists, the like, to actually formulate a whole care plan for the patient? And
so we have, and we write down a care plan, or our assessment, which it includes a chart review, or whatever they have available.
Okay.
And getting the history, writing down what are their insurance, what are their insurances, who's their contact people, what is their daily routine. Very important, because gives a sense of how they're sleeping, what their function is, what they're doing all day. History of present illness, past medical history, surgical history, who their docs are, where they, where they reside, what their phones are, and we have a whole format, and then uh, their meds, who ordered them for what reason. A lot of times we find that, we do a sitting and standing blood pressure. They tell
Yeah,
the
or the
wrong
sets.
direction.
Yeah. Yeah.
And we and so we try to address that, and a lot of times they're over medicated. It might have been that you know their blood pressure medication hasn't changed in 10 years and they lost 20 pounds since then, or something like that, or they're on you know they complain of certain pain, so the doc gives them something, and then that didn't work. They give them something else. They didn't take the one away, and they just add, and things are out of control. I mean, 9, 10, 11 medications, like, how can it not be out of control? So we address that, and make some recommendations for considering de-prescribing. We'll go to the doctor's appointment if you want. I mean, whatever it takes. Um, and so assessing for fall risk that way, because that can be catastrophic. So in terms of the type of care that the person needs, we do make recommendations. So a home health agency, we don't advise that people hire on their own. We understand why they do, but you're exposing yourself to theft or injury or whatever.
Yeah. Yeah.
Okay. Number one. Number two, if we recommend a home care agency, we have certain models that we like. We want, one that's local. We know the owner. We have his cell phone number. If there's a problem, we call him up. Okay. We tend not to use the franchises because the margins in home care are so thin that, you almost have to cheat, like send out a homemaker when you need a home health aide. They're not trained to put their hands on you. That would be a frequent thing that we would see. Um, we like we we don't get many referrals for assisted living because a lot of times people are too sick for that. Like, by the time they're ready for assisted living in their mind, they're ready for skilled.
Yeah. 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 Yeah.
That whole thing.
So the client will kind of pay for this assessment,
Yes.
private pay. You develop all the care plan, and then what, you tier it according to their needs. So if you want us to come to your doctor's visit with you, if you want us to collaborate with and make a recommendation partnership with a home health care agency, et cetera, et cetera.
Yes.
Okay.
Yeah. So
And
we'll coach the family through it, or we'll take charge depending on what they need. If they're not
gotcha.
around, they don't live close by, we'll make a recommendation that, at certain, appointments will be there,
Okay. Okay.
So
Okay. And where are you located?
we're in Haddonfield.
In New Jersey, because we have this is an international audience.
Yeah,
So
so we're near exit for the New Jersey Turnpike. We are, 10 minutes from the Philly bridges. We cover a 50-mile radius, so we cover all South Jersey, down to the shore. We cover Philadelphia and western suburbs. Most of our clients are, because of our referral patterns, are in the Burlington, Camden, Gloucester County areas, which border the Delaware River. I have other nurses that work with me. They have expertise in long-term care. I have a nurse practitioner, psych nurse practitioner, who I call when I need her.
yeah,
It comes in handy sometimes.
absolutely.
You
And so do you do any remote offerings in terms of, do you do remote consultation for people that may not be in your area, but could benefit from, having a plan?
We can. I mean, we like to visit them where they live, actually. Just go into someone's home, you can tell a lot about what their value system is, what their function is, what's
Yes.
important to them.
That's why I love a good house call myself. I do.
Yeah.
But there are, I think the ways in which we're trending and the need is great for understanding. I think, my why and angst at the same time is that we can't argue and bark caregiver overwhelm if we don't take the time to educate ourselves and educate one another at bedside. So, this is important work that you're doing. Do you have a website?
We do. lifespancm.com.
Lifespancm.com. Beautiful.
Correct. Yeah.
Okay. And Mr. Newell is the owner of the company. And I would suggest you reach out if you're definitely in this immediate tri-state area, it seems. But I would think an in-home consultation is best to navigate the unique care needs of your loved one.
Before there's a disaster?
Right, beforehand, right? I think that has definitely been the theme of the Care Pod this year across many guests is the prior preparation, right? What do you say to someone like yourself or myself that is the young old, right? Where we have the opportunity to kind of make these early decisions, we're in the know. What would your top 5 be of things to do now?
Well, I think you want to have a coherent, records, of your encounters. You really want to know what medication you're on and why you're on it,
Yes, the why.
Yeah. The why you're on it, and have a sense of your own kind of quality of life, physical functioning, and, recognize, not just ignore when you do have a step down in terms of your physical functioning, or cognitive functioning. So a lot of times we see people that are not able to do their instrumental activities of daily living, and the families are kind of making excuses for them. But poor judgment is coming into play, which is really the first sign of cognitive impairment. Right. They are cognitively impaired. We just don't have a diagnosis. And so that's what can we do to back out of that, or assist that person to back out of that, or at least be in a safe space so that they don't make judgments, that are going to hurt them.
Yeah, that are not safe. That's a good one, because I think that's also separating the emotion, right, from the practicality and the logistics of things. So, she just, forgot the stove on. It's no big deal, right? But it is,
burn the house down.
it is an acceptance, right? It's those 5 stages to say, you know what? I think we need to take a closer look, and also having those conversations across siblings, the like.
So if we think about, a lot of times we're able to say things to the parents that the adult children cannot say. And what I tell the adult children is, think of it as this way. Emotionally, it's like you were 7 years old and your parent was 35, right? And they knew everything, you knew hardly anything. That's not the case anymore. Okay, the roles are reversed. You need to be able to feel okay stepping up
and setting those boundaries.
Don't feel comfortable saying the truth, we will say the truth, because if you're not dealing with the realities, then things are not going to go well. So
very important. So last words for our Care Pod audience?
I think it's all about caring. Like, if you care about your parents, if you care about your loved ones, you kind of take that extra time to, give them some feedback, observe, note, give them some feedback about what's going on, and let them know that if you're not safe, you kind of need to lose your vote on those, certain things, or else it's going to be sad for everybody.
That's it. The choices we make. Yeah, it's so true. Well, I really enjoyed our conversation. Again, lifespancm.com, correct?
CM.com, correct.
Okay. Thank you, Mr. Newell, for being with us today.
Well, thanks for the opportunity.
Yes.
Great information right from the source. For more information on how to caregive like a boss, check out impactfulcaregiving.com. Want to be a guest on the show? Contact us at CarePod at impactfulcaregiving.com.